Okay.
And recording as well, then we start.
Okay.
I think you need to start recording and then we admit all people.
Uh, yeah, recording on this computer. That's fine.
Okay.
So, appearing here. Okay, it's appearing. Okay. I'm now going to admit all people. Okay.
Okay.
Let us start.
Shall I start?
Yeah.
Yeah, just wait. People, let them join.
Okay.
Assalamu alaikum, everybody.
Assalamu alaikum.
Doctors are this side. You are.
Seven, if you can mute all and start.
Assalamu alaikum, everyone. First of all, if you can can I request that you all keep yourself muted? So I would like to thank you all on behalf of the Impact team for joining. And I would like to thank Government of Sindh, Health Department of Balochistan, Punjab, Vice Chancellors of all attending medical universities, and everyone else who is joining separately. So before we go on to our main part, I just briefly would like to tell you about the Impact. So Impact is a UK-based non-profit professional organization, and which is promoting transfer of the medical knowledge and experience with all the professionals across Pakistan. So as you know, in the current COVID situation, there are certain group of patients, people who are more vulnerable for increased morbidity and mortality. And in such groups, we have patients who are diabetic or have cardiovascular disease. So today we have got two excellent speakers with us who will be sharing their experience. So first of all, I would like to introduce my first speaker, who is Dr. Kashif Rizvi. He's a consultant in internal medicine, diabetes, endocrinology, working in Clover Center, Kuwait at the moment. He has extensive experience working in UK and is a tutor of the Royal College of Physicians. So over to you, Dr. Kashif Rizvi. Dr. Kashif Rizvi, can you please unmute yourself?
I have. Good
Yeah,
morning. Thank you, Dr. Samreen, for that kind introduction. And I have to apologize to all the people watching because, you know, this technology thing is full of glitches. So if somebody's electricity goes off or if I fall off this chair, please forgive me, okay? So I would try to start this very delicate process by first sharing my screen, okay? So wish me luck. Right, so that was quite good, I think. I hope that all of you can hear me. And as Dr. Samreen said, that every now and then when new people will join, I've been given the task, if there was any echo or any noise, to mute everybody. So after this 45 minutes or so, when we go through this discussion, there will be a 15-20 minutes question and answer session as well, which can be conducted in Urdu, Punjabi, English, except for Pashto and Sindhi, everything else is okay. So I will start my conversation. I'm sitting in my clinic, as you can see. And I've given this talk the title of Diabetes with Obesity and COVID-19. Now, you know, you're all, mashallah, trained physicians, and you can see there is so much hullabaloo and fuss around the world with COVID-19 pandemic. And quite rightly so, because it is a catastrophic event, the likes of which we have never seen in our lifetime. It is shutting down economies, airlines, and, you know, just to give you an example, one of my friends who works in Emirates Airlines once boasted to me that, look, Kashif, we have 150 planes in the air at the same time. So now there is hardly any plane of Emirates in the air. So you can see the impact of COVID-19 is very acute and very severe and wholesome, multidimensional. But what we have as physicians specializing in diabetes emanating mostly from obesity, which we will talk about, is the pandemic which has been in place for the last 50 years. And that is the pandemic of diabetes and obesity. You know, it kills way more people than the COVID-19. It has enormous morbidity, weight on the health services. And when I was in the NHS for a long period of time, going through the junior ranks to the senior ranks, you know, this particular problem has blighted our health service in UK enormously, and I'm sure in Pakistan as well. So we will talk about these three things one by one and then together, and then inshallah we will do the question and answer. I'm speaking slowly so everybody can hopefully hear me and understand me. Dr. Samreen has already introduced me very kindly. So I'm currently a consultant in internal medicine, endocrinology and diabetes here at the Clover Center, which is a standalone endocrine diabetes center. I was head of the Department of Endocrinology and Diabetes in East Midlands in Kettering, UK. I have the board certification in both of these specialties, and I am a member of all of these bodies. So just to reiterate the point that, you know, what you're seeing these pictures of COVID-19 across the world, Johns Hopkins have made an excellent dashboard where people can see live information of people affected by COVID-19 around the world. But this is a similar dashboard of the world in front of you, where you could see about diabetes, and you can see the projection is absolutely enormous. You know, like in 2003, 194 million people had it, and in 2025, which is not far from us, 333 million people have diabetes. But you know, in UK, we used to say the missing million, that for every one person who is diagnosed with diabetes, there are one or two other people who are not diagnosed, and they do have diabetes because of the paucity of symptoms. So you guys will pay your attention that in the North American region here, we expect a rise of 57%, but in Africa, look, 111%. So you can ask or whisper to the person sitting next to you why it is so high in Africa and why it's not so high in America or Europe, right? So there's a brief pause. The answer to that is that, look, they already have it, 23%. And in Africa, it's 7.1%. So it will make a start from a lower position. And this global pandemic has been present for the last 50 years, as I just said. Now, what happened? You know, diabetes is not anything new. As you can see, way before we were reading Lancet and New England Journal of Medicine and BMJ, the Egyptians were very smart, and they were writing their own medical papers 1500 years before Christ, which is called Ebers Papyrus. And in that paper, the physician, or herbal medicine specialist they used to be called, describes a disorder of frequent urination and weight loss. So this is the most ancient description of diabetes, which basically means in Greek leakage, siphon, and mellitus means honey or sweet. So it's the leakage of the sweet substance, you know, as compared to diabetes insipidus, which is the leakage of water. So this is a very important thing. I'm making this presentation fully knowing that almost all of you are well trained in diabetes and endocrinology. So you ask your colleagues or think in your own mind for a moment that what is the most important thing for yourselves or a healthcare provider who's visited by a diabetic, or GPs, Dr. Samreen, when you're encountered with a patient of diabetes, what is something unique that you could provide them that nobody else can? They already have checked their sugar. They know it's high. That's why they've come to you. So what is the USP of a doctor who deals with a diabetic patient? Of course, that is to make a diagnosis, right? So always remember that raised blood sugar or a persistent state of hyperglycemia is a state. It is like anemia or increased urea or creatinine. So if you find somebody with increased creatinine, you won't start treating them, right? You will want to make a diagnosis first, whether it is pre-renal, renal, post-renal, So similarly in diabetes, it's very important to establish clinically, supported by biochemistry, the underlying diagnosis which has resulted in altered handling of the blood glucose. So if you split it with that diagnostic criteria, you will split it into type 1, type 2, and some in the middle. Type 1 diabetes, as you know, is a characteristic one-dimension disease where it's known from beginning of time what happens, not the immune markers, but the process. And as you can see that it results from the autoimmune destruction of the pancreatic beta cells. Please remember this because it will become important when we discuss COVID-19. Now, the markers of this immune destruction, there is a hypothetical scenario that the virus comes, and after the virus, the immune system goes in overdrive. Again, remember COVID-19, we will talk about. The overdriving immune system will create these antibodies, which are of 3 different types: the islet cell antibodies, the insulin antibodies, and antibodies to glutamic acid decarboxylase, the GAD, anti-GAD antibodies. The islet cell antibodies and insulin antibodies, they will go up and down. Their titer will go up and down when the disease process is in place. They will slowly disappear. But almost 90 to 98% of the people will have the anti-GAD antibodies. So if you find somebody thinner with a lot of symptoms, relatively younger, any lab you can check the GAD antibodies because you can make the diagnosis of type 1 diabetes, and you then prepared for glycemic toxicity, ketoacidosis, and things like that if they were not treated with insulin, right? So that's type 1 diabetes. Now, before we go on to type 2 diabetes, I just want to make my point that not all diabetes are the same. So there is this so-called MODY, the monogenic diabetes, as you can see on your screens. I think the Impact will be able to provide you a copy of my presentation later, so you guys can study it in detail. But you can see here there is a genetic defect. This is a secretory problem, and you could put them on sulfonylureas in this situation. In this situation, let me just mute. I think the person who just entered, can you please mute yourself? Right. So the monogenic diabetes is characteristic. You can find an incredible family history. The mother, the auntie, the uncle, everybody has it, right, in the family. So you can do the whole family tree. And it is treated with simple sulfonylurea, which is a drug that we only use now in specific diabetes like this one. Then you could damage the entire pancreas, right? Again, attention, COVID-19. So you can have pancreatitis, you could have trauma, you could have anything which destroys the pancreas. Here, the exocrine as well as endocrine, both functions of the pancreas will be destroyed. So you will suffer with malabsorption. So you must replace with creon or the pancreatic enzyme. to achieve good health, plus they have the type 1 diabetes of destruction of the islet cells. Then you have all the 6 hormones which oppose insulin, the growth hormone, the cortisone, the glucagon, the catecholamines, and they can all create diabetes with these conditions like acromegaly, Cushing syndromes, etc. And it's very important for you guys to please don't miss these diagnoses. You know why? Because in endocrinology, at the beginning of a problem, it's very easy to treat, but very hard to diagnose. But as the problem progresses, the appearance changes and it becomes very easy to diagnose. You could diagnose in a train or a bus, but it becomes very hard to manage. So when you diagnose these conditions that I have put down, the salient feature is that you could actually cure this diabetes by removing these lesions. Then many drugs like a glucocorticoids, again, attention COVID-19, can induce diabetes or worsen diabetes. Thiazide diuretics we used to use a lot for blood pressure, and they used to uncover diabetes by creating a slight dehydrated state. And then so on, it continues, the list continues, and list continues, right? So now we move on to the bulk of this diabetes, the epidemic or the pandemic that I was referring to. What happened in the last 50 years? What happened is that you can see this young man here. He's going to school from a village, right? He's got his books on his bike and he's got no established road. So he has to go up and down. He has to make an effort. He has to move his pedal. And you can see that he has got not an ounce of fat on him, right? So in this current day and age, his mama will be saying that my boy is not healthy, you know, he's so thin, and take him to the doctor. And again, this guy you see here, who is plowing the field, you can see he's done almost all of this field. And this guy has got no fat on him whatsoever, right? And this is what has happened to us in the last 50 years. I mean, this cartoon is a little depiction of that. You can see that you could argue this is a scientific thing. It was maybe against some people's views, but from Homo erectus to Homo sapien, it took 2.5 million years. And when the man was walking upright, it didn't take him long to sit on this couch and watch TV and have McDonald's and all of these things. So you can see the difference from here to here is absolutely incredible. And what happens? You know, like you guys will wonder that you don't eat anything extra. People try very hard to lose weight. They will come to your clinic saying that, look, we swallow air and we get fat. But basically what happens is this very interesting slide put out by Mayo Clinic, that if you are sitting down for talking on the phone, you will burn 4 calories. And if you stand up, you will burn 20 calories. Similarly, if you hire someone to, I need to just learn quickly how to mute when I've got the full screen sharing. Where is this? Anyway, I can't find it on this full screen mode. So when you're waiting for pizza delivery in your house, you'll burn 15 calories. And when you're cooking for 30 minutes, you burn 150.
Sorry, Dr. Kashif, your slides are not coming up. If you can share your slides.
Okay, just 1 second. Are they coming now?
Reshare again, I mean.
Yeah.
Okay, so let me quickly go down to where we were. We were here, right?
Yeah.
So you guys can all see my slide now?
Yeah, you can go to slideshow.
Yes, but I don't know how to mute all from there. So you'll help me with that one and I'll unmute myself if somebody comes in. Okay, so all good again. So I was just making a point that this is not some kind of miracle which makes everybody fat. It's like if you are getting someone else to wash your car, you will burn 18 calories. And if you're washing your own car, you will burn 300 calories, right? And similarly, if you are taking a lift to take you up, you will burn obviously no calories. But if you're walking, you will burn a lot of calories. And if you're shopping or sending someone else for shopping to the shop or online yourself, you burn nothing. But if you go to the shop, get your own groceries. And I used to say when I do this lecture to an audience that if you're sitting and listening to the lecture, you will have 30 calories burned. And if you were actually myself giving the lecture, it would be double the calories burned, right? Similarly, you can see that in a 24-hour cycle, how humans burn energy. And as you can see here, this is, I'm going through a little bit quicker here, that the energy level is burned continuously at a constant level. But when you start to get your kids ready for school, look, it looks like what you get in a 2020 cricket match. You know how the energy consumption increases. When you start to sit and drive to work, it again declines. Even if you go to the gym, you can't almost match this, getting the kids ready to school. And when you're in your office, even visit your friends, don't write emails, you know, who are sitting next to you. And similarly, when you're sitting watching TV, it goes again to the same situation. So what happens gradually over a period of time, all of us invariably start to gather this fat in the middle of our body, the central or adiposity, which is visceral, you know, it is sitting in the middle of the body. Now, this is the key message. The fat, there is nothing wrong with the fat inherently. God made fat to go under the skin, which we call subcutaneous fat. So it will cushion you like a blanket, right? It will do nothing but cushion you under the skin. But when the fat enters the cavity of the body, it becomes metabolically active, like a radioactive substance. It starts to cover the receptors of insulin on the muscles and on the liver, and it also starts to secrete pro-inflammatory markers that I will mention in a minute. So this person with the central adiposity has gone to the doctor, and doctor is listening to his heart, but really his cardiac risk factor is all sitting here in his abdomen. So when the abdominal obesity increases, remember that we don't realize it because the limbs are relatively thinner. I hope you guys can see me, right? The limbs are relatively thinner, so people look at only their limbs. And when you go on a holiday or something like that, you suddenly realize that, oh, what happened? You see a picture of yourself with a huge tummy. So these free fatty acids are injuring the pancreas. The over-secretion or the work the pancreas has to do to overcome resistance of insulin is exhausting the pancreas. The sugar load, which is slowly increasing, is damaging the pancreas. And as a consequence, you can see that diabetes is diagnosed when the sugar handling of the body becomes impaired. And the process, if you look around this august audience listening to this talk, you can all look, including myself, at ourselves, and you will see that the process started long before, maybe 10 to 12 years before, and then we reach a crucial tipping point where diabetes is diagnosed. So this is now the second part of this conversation. When we get to this point that there is insulin resistance because insulin cannot put the sugar into the muscle, 80% glucose disposal, into the liver, 10% glucose disposal, GDR, it starts to store it in the fat, which is 1 to 2% normal disposal of sugar, or it starts to float in the bloodstream combined with the red blood cells, which we call hemoglobin A1C, and we monitor it for managing diabetes control. So this insulin resistance, if you think for a minute away from the sugar itself, which is the top, the hyperglycemia, forget about it. It is creating lipid abnormalities, hypertension by retaining sodium and stiffening the blood vessels, damage to the blood vessels, and it also creates the environment for clotting abnormalities. That's why we put these people on aspirin usually if they have multiple risk factor, and it creates low level inflammation. So if you check their CRP, you will find it slightly elevated. So then we move on to the COVID-19 situation. Now, COVID-19, the coronavirus infection, we're now going to combine the two pandemics that we have of diabetes and obesity. Just a brief mention of this COVID-19, I will quickly mention that think of the virus as a seed sitting somewhere, right? It is not moving around, it's just sitting somewhere. So it needs to be brought into you. So you will either inhale it, right? Wear masks, please. Your key area, nose, mouth, and the two eyes. So you will either inhale it or you will touch your hands somewhere and rub it onto your eyes or your face. So the virus will then gain entry into your body. Once it gains entry into your body, this stage 1 will start. Your body will start to react to it and try to contain it with mild symptoms of fever, which is not very high, like in Pakistani terms, less than 101. And you will get a very typical cough of COVID, which is right. So there's no sputum or bulgum production, and you get headaches as well. Now, as the virus is stationed in the right upper part of the nose, and it's not a rhinovirus, you will get congestion of the nose, but it's unusual to have runny nose. Runny nose will suggest cold. So stuffiness at the top of the nose and irritation at the base of the throat. And this is the two places when it becomes bigger or more advanced, it will cut off the supply to the brain. So create the loss of smell sensation and the taste sensation, which almost diagnostic of COVID-19. If one of your patients says, "Ki meri smell ki sense, I have lost smell sensation or taste sensation." So at this stage, the virus is still contained and the blood is reacting. There's little lymphopenia, there is little increased prothrombin time and D-dimer. This is all mild. And if you are in low risk category, you're young, you don't have this pandemic of diabetes, obesity, hypertension, and smoking to contend with, you will get better. But if you are one of those people who has the obesity and diabetes and hypertension, and strangely, if you have A positive blood type, you may go into this area where the immune system goes into an overdrive. Because when the virus comes into the human cells, it replicates itself. It then leaves the cell wearing some of the cell membrane. So it kind of confuses the inflammatory response, which goes into overdrive, the so-called cytokine release syndrome, or there's many other names for it. So this response then becomes life-threatening, because this response will hugely elevate your inflammatory markers and cause the worsening of the respiratory function. If you are at home, the oxygen saturation will go below 94%. You will be tachypneic, breath rate more than 28 per minute, and you may have altered sensorium, that you become confused. This is the time for the person to move on to the hospital, right? So here, potential treatments we will talk about in a minute. Anti-malarials, unfortunately, please don't use them, because a big study was prematurely stopped. They can cause arrhythmias, this chloroquine, and cause sudden cardiac death. So the safer ones are the convalescent plasma and this nucleoside analogs like remdesivir, or immunosuppressant, the IL-6 inhibitors like Actemra. They have the mileage in this host immune response overdrive alongside dexamethasone. So you can see here in the COVID patients, this is the hospitalized data. You can see, ignore the children, because fortunately this virus is kinder on kids, alhamdulillah. But in the adult population, you can see there are three big markers here: hypertension, diabetes, and obesity. If your patient has these three, then please remember, if A+ blood group is there, there is a huge possibility that they will go into the hospital. So you prepare accordingly. So just now the last part of this presentation, I will talk about the obesity and diabetes and what are the things you do to a diabetic patient when they are under your care in the hospital. So I've written here that obesity is a very important determinant of the lung volume and the mechanics. Please remember that a fat person over BMI of 30 has a very limited real estate in the lungs. So if he's lying on his back, his respiratory tidal volume is very small. And if you put 60–70% of COVID pneumonia on top of it, then it becomes an impossibility. And in old days, we were putting them on ventilators and they were not coming out alive. So please try to prone them. If they are on their face, lying face down, you will open up the entire back and bottom of the lungs, and their oxygenation or saturation will be much more easier to maintain without mechanical ventilation. Because remember, my friends, that there is 90% mortality on the ventilated patients in this condition. So the whole emphasis is on stopping them from going onto the ventilators. The people with diabetes and obesity have an altered immune response. Their immune system is sluggish. Their neutrophils are slowed. Their phagocytosis is delayed. They have a lot of inflammatory environment with this leptin and reduction of adiponectin, the obese people. They are also usually physically inactive. So they have insulin resistance, which drives this inflammatory environment. So just a few stats that you can see that 20 to 50% of people who come into the hospital have diabetes, and almost always coexisting obesity. It was because, this is a novel new coronavirus. We have to go by the previous ones to find objective. This MERS, which happened in Middle East, you guys will all remember, this diabetes was a chief contributor to mortality. Fatal outcome up to 50% higher in diabetic people. Okay, if you could mute all, then I can unmute myself. Try to keep quiet, please. Okay, excellent. Thank you so much. Thank you, host. Now, when we are in the throes of this situation, the elevated hemoglobin A1C is very, very important, right? Again, I will request. Okay, apologies. I hope you are still with me. Is this in?
Dr. Kashif, please unmute yourself.
Right. Thank you. So, can you request everybody to keep quiet, please? Thank you. So please remember that when you admit a patient with diabetes and COVID-19, you have to contend with two problems. One is their weight, and one is their HbA1c. Right? Maybe ignore this background chatter, and I'm sure you guys are all paying attention. Now, HbA1c and weight, you cannot do anything about when they come into the hospital, except that you brace yourself for problems. But remember that you can treat them very appropriately in the hospital to mitigate this risk that they have. Right, so let me just see if I missed a slide. Yeah. So obesity and diabetes, just to recap, they are global pandemics already. The people with obesity and type 2 diabetes are frail physiologically. Their immune system doesn't work because they have low-grade inflammation. Their interleukin-6 and CRP is slightly elevated, right? And they have disorders of all sections of immunity. As I said, this presentation is available to everybody who is listening to this talk. Right. Now, this is a very important point which I mentioned before. When the virus, this coronavirus comes into your body, the door or the lock that this virus key or the spikes attaches to is the ACE2 receptor. And all of you, I'm sure, know that ACE2 receptors play a basic fundamental role in regulation of blood pressure, and they are located on the lungs, on the heart, and on the bowel. Right? Now, when the virus goes and attaches itself to the ACE2 receptor, it opens the door for him and he goes inside the cell. So there is a query. Please mute all. Thank you. So the virus is gaining entry. I'm just emphasizing this point because it's a very crucial point. Through the ACE2 receptor and the DPP4 receptor. Remember, you guys use sitagliptin and all the other gliptins. The ACE2 blockers and ACE inhibitors are the mainstay of our treatment in hypertension and diabetes, and so is the gliptins, DPP4 inhibitors. So these are the 2 points. I just will dwell for 1 minute. The expression of ACE2 is also on the pancreatic cell itself, islet. So if it is damaged by the coronavirus, you could see type 2 diabetes change into type 1 diabetes of insulin depletion, right? Or somebody who's non-diabetic could become diabetic when they are in the hospital with you in this cytokine release syndrome or severe disease. Right, so I need there. Now we reach all the treatments of diabetes that you normally employ, right? So a few minutes on this. Everybody in type 2 diabetes, if they have central obesity or even not, they are on metformin, glucophage, okay? When they come into the hospital, glucophage is a good drug, but it can accumulate, especially when there is dehydration. So please, I would be inclined to take them off it. Now, the next drug is this SGLT2 inhibitors like Forxiga or Jardiance, right? Empagliflozin or canagliflozin. These drugs are very deceptive because they actually work through throwing the sugar out of the kidney. So sometimes when people are reluctant to use insulin type 1 diabetics, some GPs, like even in our region, they treat them with these drugs. So these drugs can cause the so-called euglycemic ketoacidosis. Like you get the ketoacidosis, but your sugar is not that raised. So be aware of that and also stop them because they will encourage dehydration in the hospital environment. Then we have the glucagon like GLP-1 analog. Again, mute all, please. Humble request, last few minutes, we stay focused, please. So the GLP-1 analogs, you know about the older one, exenatide based, which are very toxic. We don't use them, Byetta-like drugs. So you have liraglutide, which is Victoza. You have dulaglutide, which is Trulicity. You have semaglutide. I don't know whether you have in Pakistan. It's called Ozempic. They are good drugs, you know, but you just need to monitor people very carefully because they're longer acting once a week drugs, but you don't need to stop them. DPP4 inhibitors like Januvia and drugs like this, sitagliptin, saxagliptin, linagliptin, are safe. They can be continued in the hospital. The sulfonylureas and glitazones are toxic drugs. We don't really use them in diabetes anymore. And this acarbose like drugs don't work and they cause diarrhea, which we don't want in this situation. Insulin. If somebody comes into the hospital and they're on insulin, please obviously continue the insulin. But remember that subcutaneous insulin absorption will be very erratic in a very sick person. So we always treat them with an IV insulin infusion because IV insulin infusion, you can increase and decrease. Please remember in the COVID-19 patient, there is a large insulin requirement in some patients. So don't hesitate. You know, even 20 units per hour is required in some people. And when you've got them on IV insulin, there will be fluid with it. So remember that if you have COVID pneumonia, you can easily induce pulmonary edema because of their usually cardiac function is compromised. So watch the fluid, continue the insulin, change to IV, monitor the sugar frequently, and discontinue all drugs except Januvia like gliptins if you have to. Otherwise, my personal preference would be to treat them only with insulin. Now the question is, people who are taking Diovan, Irbesartan, all of these Coverseal, Zestril, Ramipril, what do we do with them? Initially, there was a fear that they, as their ACE receptor blocker, could actually upregulate, like make more receptors available for the virus to enter. But there is no real evidence from any study that they do so at the moment, because I think they offset it by decreasing the angiotensin II enzyme activity. So please keep people on them, because the control of blood pressure is much more important rather than a theoretical risk to them. The other drug is the non-steroidals. We encourage people only to use paracetamol and avoid the Brufen-like drugs, at least in the initial phase of this illness, because they can also open up the ACE2 receptor, and there is concomitant risk of injury to the stomach and acute tubular necrosis of the kidney, which becomes much more pronounced if a person is dehydrated. So try to manage them only on paracetamol. Statins, again, they can theoretically upregulate the receptor of ACE2, but there is no evidence so far that it will do. It is a pleiotropic effect of anti-inflammation, so we will encourage you to continue the statins that they have. So lastly, if they are in the hospital with you, and if they have more than one risk factor of hypertension, diabetes, obesity, and smoking, then please look for these, that they have the lung disease already, coronary artery disease, heart attacks, arrhythmias, etc., and all of the high inflammatory markers. Remember, the sugar is a very potent inflammatory marker. So in any infection, you will struggle to lower the sugar until the infection has been lowered, right? So it's a bit like ferritin and CRP. The sugar itself is a marker of inflammation. As we discussed, that we stop the medication in these people, the oral anti-diabetic drugs, and we treat them with an IV insulin infusion, okay? And lastly, my message to you is that this is a terrible, catastrophic disease. My hat's off to you, really, because you guys are at the forefront of it, sometimes with inadequate PPEs. We are losing our colleagues, doctors, nurses in Pakistan. Our hearts are heavy, but really the onus is on us. We also have this absurdity to deal with in Pakistan. There are 3 different types of it, these so-called totkas, that you have people, okay, you can have hot water and kalonji, but they're not going to harm you. But there is some bizarre thing called senna makhi, for example. It's a laxative, so it will cause diarrhea. And when you're in the throes of this disease, where hydration is very important and protecting your energy, you don't want to have diarrhea, and it's obviously not going to help you in any shape or form. The third very absurd thing I hear from Pakistan is that, oh, you know, our patient was fine, we took him to the hospital and they killed him with a poisonous injection. I mean, it's a shame that there is no government spokesman or there is no doctor's hierarchy which can address this ridiculous thing. You know, in COVID-19, people can tolerate hypoxemia to a ridiculous level, like their sats will drop to 60s and they will still be sitting reading newspaper. So when the relatives bring them to the hospital, they are already very, very sick. So the hospital will try dexamethasone, try remdesivir, try Actemra. They can only salvage some of them. And the people then get the perception that they took them in isolation and killed them with their management. So there needs to be some public awareness campaign to stop this ridiculous nonsense. Remember the risk of old age. Old age per se is not a risk, remember. You will see videos of 102, 103-year-olds recovering from COVID-19. It's the biological age rather than the chronological age of an individual. You will see some 50-year-old who look like 30-year-old and some 30-year-old who look like 50-year-old. So don't get too fussed on the age. Focus on the central: obesity, bad news; diabetes with HbA1c over 8% at admission, bad news; hypertension uncontrolled; and curiously, A positive blood type. 45% higher risk of respiratory failure with A positive blood type. And if you have O positive, there is a 30% reduction in the risk. So pray that you are in a blood group type other than A positive. Prepare for the cytokine release syndrome. Get the breathing exercise. Lay your patient prone. Don't use nebulizers, please. Remember that if you use nebulizer, the virus, which is stationary or static in the upper airway, will be dispersed far and wide into the entire lung fields with a subjective improvement of the patient for a few minutes. And the nebulizer will make them cough, which will throw the virus particles in the air for all the people, even the nebulizing person and relatives, to catch the virus. So there is absolutely no help from the nebulizer here. None of the home remedy is effective, as I just mentioned to you. Encourage people, which we are doing into Pakistan, of getting themselves this pulse oximeter so they can monitor their saturation, which is really a very simple and effective tool against this. Right, so there I will stop, and I am very happy to hand over back to our moderator. I have finished in 45 minutes. So I'm happy to answer any questions from anybody in any language, I must say. Thank you. You need to unmute yourself, Dr. Sameen, please.
Sorry, yeah, I kept muting others, and then I forgot to unmute myself. So thank you so much for this really informative session. And as you already mentioned, that it's important that diabetic and
Professor Saab, 1 second, please.
Yeah.
Okay.
Sorry. Yeah. So as the diabetic patients, they are high risk. So it not only it will affect what the condition they have.
Sorry, Sameen, I've muted everyone once again. If you want to unmute.
Sameen, you need to unmute yourself.
Yeah. Sorry. Yeah. So we are ready for the question answer session. So if anyone has a question, they can just unmute and raise hand, or you can send your question in the chat box. And can you please introduce yourself? Yes, please.
I am Professor Bizat Mashir. My question is, when you have got the COVID patients and severe bronchospasm, if you don't use the nebulizers, how are you going to relieve the bronchospasm in these patients?
Sorry, I didn't quite catch your question. I think it's about the nebulizer.
So yeah, he's saying that
majority of the patients, they have got the severe bronchospasm. And if you are not going to nebulize these patients, how are you going to reduce this bronchospasm in these patients?
I think that's a very good question. This is where the patient has moved on from the home to the hospital, and they already have the virus spread everywhere and the CRS in place. Here you are using dexamethasone or IV glucocorticoids, which you would like to avoid in diabetics, and you will have to nebulize them as well. So I'm talking about the home people who are in a mild illness, who are coming to a recovery phase. That, you know, in Pakistan, everybody has a nebulizer, for example, in their home. So here you have to use your judgment, and I think when you are on IV glucocorticoid, it will help your spasm as well. Thank you.
Can I please request only the person who's asking a question unmute yourself? Rest of you, please keep yourself muted. If there is anyone else who likes to ask a question, you can also send in the chat box.
Yes, sir.
please. Can you please introduce yourself first?
Dr. Saeed Ansari, RHC, Sobadara District, Khairpur, Sindh. I have a question.
Gigi, yeah, go ahead.
The type 2 diabetic patient who comes to us, sir says that stop the gliptins and metformin. Can we switch over this patient on insulin for time being? And which insulin?
That's a very good question, Dr. Atta. I personally, if you go into some years ago, there was studies called Degami studies and things. You can, when somebody is being treated with insulin in an acute situation, they usually have a better outcome because of A, insulin being a protective and anabolic hormone, and B, mitigation of discontinuation of oral therapy. So I think you are absolutely right. Even when you're using sitagliptin, for example, there is not much mileage if you have them on an IV insulin infusion, because this is a race with the glucose in a sense. And you're absolutely right. All of our patients here in our hospitals that I treat, we have them on IV insulin infusion in COVID-19. And one thing I forgot to mention is super added bacterial infection. So please be on guard when you're using dexamethasone, and cover with a large, ceftriaxone we use conventionally, but we do use levofloxacin and tazocin in situation where it seems out of proportion.
Thank you.
You have a question, please?
Yes, please.
I'm Professor Amir Shahzad from Rawalpindi. I'm Director Academics in NUMS. I have a question. What's your experience of using Actemra in diabetics versus non-diabetics? Is there any difference in response to those patients?
That again, Dr. Amir, is a very good question. The problem is that novel virus is a new thing, and everybody is getting anecdotal and very small, non-peer-reviewed evidence, etc. I hear very good reports in some people with Actemra and diabetes because it does suppress interleukin-6. But in some people, there's a rebound from it as well, and they get worse. So, the only drug which in my opinion is safer and probably going to be effective, now this is speculation, but based on some evidence, is remdesivir. If you select early, and the convalescent plasma, which we have been using for 100+ years in pandemics like diphtheria and smallpox, etc. So there is a large study in place from Johns Hopkins with several thousand hospitals around the world for convalescent plasma. So I'm hopeful with that. Actemra is a drug which in some people in diabetes is successful, in some people it isn't. There is no study to back my claim.
Yes, please unmute yourself and speak. Is it Dr. Brig Azhar?
जी अस्सलाम डॉक्टर काशिफ रिजवी थैंक यू वेरी मच बहुत ज़बरदस्त आपने सारा सब्जेक्ट कवर किया बेसिकली कोई आई एम नॉट practicing or clinical clinician but just had a question that you said that the Nevaquine trial had to be stopped because of suicide effects or cardiac effects. So are these effects specific to its use in corona cases? Because we have been using for 50 years, we didn't come across these much side effects. Thank you.
Right, sir. Thank you for the kind words. I appreciate it. There is a curious relationship between malaria and the anti-malarial and COVID-19. If you look at the whole epidemiology of the world, you will find that wherever malaria is prevalent, the incidence or the severity is a little less compared to where malaria and anti-malarials are not prevalent. So there was a hypothesis that just like falciparum malaria creates sickle cell disease to protect those people, and similarly, malaria or anti-malarials could confer some kind of immunity on India and Pakistan and Bangladesh because the mortality is like 2% or less compared to Italy where it's 10%. The problem, as Brigadier Saab pointed out there, is that we don't know, but in these people, if you use this hydroxychloroquine, they can prolong their QT intervals. And when that happens, there's like a recipe for a sudden cardiac death from ventricular fibrillation. So the balance, and there is no clear advantage of giving it in any large trials. So in terms of advantage, disadvantage, risk-benefit ratio, I think it's prudent because they usually have some mechanical, electrical abnormalities within their hearts, these people. And remember, the COVID-19 is operational on the heart through ACE2 receptors. You will see a lot of people dying with heart attacks in Pakistan. Similarly, typhoid. You know, now because the people are scared, they are misdiagnosing the COVID as typhoid because that ancient test we used to do of serology Vidal test becomes false positive in COVID-19. So people feel better if they were diagnosed as typhoid compared to this. So it's just a lack of leadership and information that people are not being advised, people of Pakistan. So, you know, we're talking to hundreds of leaders here, and the onus is on you to disseminate this information, please.
Thank you, Doctor.
Thank you.
Thank you. I've also got a question. This is from Habib Akhtar, DSO, DHO office, Khankat. I'd like to know that there is a diabetic patient, 42 years old. He's a health worker, or diagnosed with COVID positive, and now he's asymptomatic since last 2 weeks. But his 3 reports came back positive. So should he continue isolation, or that's what his question is?
Again, that's a good question. Basically, when you have the infection, you do a PCR, which becomes positive. Now, after 7 days, the person, even with the positive PCR, usually doesn't infect, like doesn't participate in so-called R rate, the throwing the virus around. So the UK government has allowed people to isolate for 7 to 14 days is really the benchmark. So the PCR may remain positive, but at 14 or 15 days, now we go back again to the older coronaviruses here, because we have history and information from the SARS and MERS. In those viruses, the antibody production, IgM, started within 4 or 5 days. And by day 15, there was 100% IgG present. So there is some immunity. We don't know whether it confers entire immunity or how long will that last. But again, going back to those viruses, 52 weeks after it began to wane, the immunity, the IgG. So if that person has got still the positivity, but he's got the IgG antibodies, he is not infectious anymore. He can be set free.
I saw a hand raised from James. If you can please unmute yourself and introduce yourself. Yes.
Assalamualaikum.
Ji, Assalamualaikum.
Walaikum assalam.
Dr. Kashif Hussain Jakrani from James Jekaba. Since last week, I am working in the COVID isolation ward. Sir, my question is that if a patient is non-diabetic and hypertensive, if patient is a non-diabetic and hypertensive already in insulin, NPH, and the ultralantin, so should we give the regular insulin for that?
I think what you're asking me is that the person is known diabetic and they're on these old insulins. My friend, we don't use them anymore, but I do appreciate that in certain situations, the cost and all those implications come in. We would encourage to go on IV insulin and continue the basal insulin alongside. The 2 basal insulins or 3 basal insulins that we suggest are the synthetic insulins. So you have either the Lantus or you have the newer insulin, which is Tresiba, that we use a lot now because it has a flat profile, unlike Lantus, which causes a hypoglycemia around 2 or 3 a.m. So my suggestion would be to take them off these unpredictable absorption and metabolism insulins and treat them only with IV insulin, which is Novorapid or Actrapid.
Yes, please go ahead. I think it's Dr. I saw a hand raised and.
Right, you were saying that you have another question from the chat or some chats, maybe?
Yeah, I will. So just give me. There is another question from Kalanda Jamali, hospital pharmacist from Sakran. So he wants to know that if a person who is asymptomatic COVID positive, will he be at risk of spreading the COVID infections to others until he appears to have symptoms?
Well, you know, this is probably the best question. And as far as I'm concerned, there was a lot of talk of asymptomatic people spreading infections. But recently, the WHO, because everybody is learning as we go along, they have suggested that it is highly unusual to have asymptomatic patient spreading the COVID-19. As a clinician, I would just mention a couple of points. That you have to inhale the virus, and you have to inhale it in a certain quantity. I mean, please don't be paranoid that somebody coughed in your vicinity, like people sitting in that big hall and somebody coughed 20 meters from them. You cannot catch the COVID-19 from just one sneeze or cough. You have to inhale enough viral load to create the disease, because the rest will, you know, like if there was 100 boxes and you throw 100 tennis balls, not all balls will go into the boxes. So inhaled viral load is determinant of how the disease, how severe, and all the other host factors that we talked about. Additionally, please remember that talking at a louder pitch will put the virus up in the air. Just to give you some perspective, the virus is 20 nanometer across. So it is 10,000 times smaller than a grain of salt, 10,000 times smaller. So if you open the door in an old building and the sunlight was filtering through, you see the suspended dance of the dust particles for a long time. So imagine if there was 10,000 times smaller than that, that will dance for many, many hours in the air. So if you're talking, you're singing, or you're screaming, there is a big chance that you will infect people around you, whether you have symptoms or obviously more virus you will shed. So in UK, for example, there is a festival called Cheltenham Festival, which is identified as the crucial point when the virus spread in the population. And similarly in Italy, there was a football match between Sampdoria, there's a football club, and another club. That's where the supporters were singing and shouting and disseminating the virus. And I feel, unfortunately, the Eid shopping in Pakistan was the tipping point, because that's where the guard was let down, and then people mixed with each other, and now the virus is on this crescendo, it's getting towards its peak. So please remember, we have no treatment for this virus. The only treatment we have really is not to get it. And there are two very simple things: that you stay away from people, 2 meters preferably, and please, I beg you to wear the mask. Wear the mask over your nose and your mouth. In Pakistan, they wear it over their chin, right? So you have to wear the mask like this. If you are wearing the mask and the other person is wearing a mask, there is less than 1.5% chance of transmission. Virtually none, right? So if you see Taiwan, small country, Vietnam has a 500 miles border with China. They have not one mortality from COVID-19, not one. Look at America, 130,000 people dead, because they're arrogant, not wearing masks, shouting against the government instruction, mixing, matching. Just please do what the Vietnamese did. Just wear the mask. It's as simple as that. Wash your hands, because the virus doesn't have wings. You will bring the virus to yourself. Mobile phone, please remember, you put it on your face, you rub the virus onto you. And we're always rubbing our faces like a monkey-like thing. So please don't rub your face and wear the mask. It will save your life.
There was a hand raised from Mir Kamran. If you can please unmute yourself and introduce yourself.
Good afternoon, ma'am. May I have to ask, I am a young female. PCR is positive 2 times and third time PCR is negative. I am doing the antibody test after 2 weeks of recovery. But the antibody test is revealed there is no antibody is active. Should I consider myself as an uninfected person or may you guide please?
This is thank you, Mia. Again, we sometimes get false positive tests, like in New York, they checked 250 homeless people and 200 of them tested positive PCR. If you have no symptoms and no antibodies, then clinically you didn't have the disease or a response. So I would suggest that be on your guard against, as I said, use the protective measures, please. And this reminds me that when people are being at home, like your friends and family, try to keep them at home, because immediately 30% mortality compared to 2% mortality at home. So try to not bring them into the hospital if you can help it, right? Obviously, if they are desaturating and all of those things. But when they're at home, select one carer which is in this lady's category, young, robust, and healthy, and not got A positive blood group and don't have the metabolic syndrome. So that person is the designated carer who can then put the mask on and look after the patient. So you protect your whole family. Don't select the carer similar to the patient. So if somebody is 60 years old, don't select their aging wife to be their carer, please. Select the carer correctly. Thank you.
Thank you. There is another question from Dr. Hamid, Doha Medical University. And I'd like to know that convalescent plasma, so do we need to go for a quantitative antibody prior to the therapy?
Yes, that's a very good question. Convalescent plasma, in one study in China, and there was a small study in US, almost retrieved 70% patients, who were all going onto the ventilators. It has a big promise, but you need to have certain criteria. You need to be ABO compatible, plus minus doesn't matter. You need to be at least 14 days post-infection, and you need to have IgG antibodies, the immunity conferring, not the acute IgM. IgG antibodies in a titer of at least 1:160. And you can use it every 28 days for 3 to 4 times to donate your plasma. But please don't fall for these people who are trying to sell their plasma, or somebody's trying to buy their plasma. Plasma is not like candies, You have to go to one of the big hospitals like AKU or National Institute of Blood Diseases. They are participating in a large trial. They will guide you, they will collect your plasma, they will then deliver it to the person that has the best chance, because they have the expertise. But in Pakistan, because of the lack of leadership, where the government ministers are saying that China has sent a category C virus to us, or another minister is saying that COVID-19 is called 19 because it has 19 spikes on it, So you have to look after yourselves.
Okay, and then there is another question from Dr. Danish Kumar, that if a patient has recovered from COVID-19, that how many chance if he can become again positive? And what are the reasons?
This is a question which is unanswerable at the moment, I have to say. In all honesty, there is some reports in China of people getting reinfected. I don't know whether they are accurate or not, but what you can do is that once you have IgG antibodies, there is a very reasonable chance, looking at MERS and SARS before, that you will be immune for a period of at least 52 weeks, which is the time we need, I feel, to get a vaccine for this condition. So I think it's highly unlikely, but it's not outside the realm of possibility.
Again, then there is another question in relation to the virus that from Zara Rizvi. And the question is, if a person has a virus shedding during the incubation period, before he starts to show any symptoms. So
that's, again, a very good question. you become infectious. The incubation period ranges from 1 to 14 days, but in our experience, we have thousands of COVID patients here that we have been involved with, is that it's usually day 2 or 3 that you become symptomatic with it. It doesn't linger for too long. And once you become symptomatic, you will definitely shed the virus. But when you're not symptomatic, there's that $1 million question that WHO is now backtracking. But remember, the virus is sitting in top of your nose to block the olfactory nerve, back of your throat to block the taste-carrying nerve, ageusia. If you are shouting or sneezing, you will disperse the virus.
I will just mention one more question. It's from Professor Manullah Basi from Dow University of Health Sciences. His question is, just give me. Some patients are PCR negative at initial time of symptoms. Considering that they have no, they have no COVID, not isolating after some days of reporting positive. What is your opinion?
I think Professor Saab raises a very, very important point. As clinicians, we have to go by the clinical situation, not by the test. Because all of the COVID tests are new and rife with mistakes. The PCR could miss the virus, the swab. So if the person in clinical setting, I will explain, it doesn't make your nose run usually. It gives you slight fever. It gives you headache, and it gives you a sore throat. These are the 3 things almost always happen. Then you also develop this cough. This cough you learn to recognize in the corridor, even sort of move away to left or right, obviously. But these 3-4 things, if present, and then complemented by the loss of smell or taste, is COVID-19, test or no test.
Thank you so much. I think we'll stop with the question answer sessions here. So much, Dr. Kashif Rizvi, for joining.
It's a pleasure. Thank you for inviting me.
Thank you so much. So now I would like to ask our second speaker. So first I would like to introduce he's Dr. Saqib Pani. He's a consultant intervention cardiologist working in Derren Valley Hospital, Dartford, UK. Over to you, Dr. Saqib Pani.
Hello, good morning, and maybe by now good afternoon in some places in Pakistan. Thank you so much for the invitation. Can I just check if I'm visible and you can hear me clearly?
Yes, we can.
Okay. So, fantastic talk by Dr. Kashif. A really, really detailed overview of COVID, especially being a diabetician, a general physician. I think his expertise and his experience was highly appreciated, and I hope people will learn from this. Before I go to my talk, just a comment and actually something to add to Dr. Kashif's talk. 2 things I really liked in his talk. One, he mentioned proning the patients, and whilst the audience is there, and before I forget, towards the end of my talk, it is so important. It's such a simple maneuver. I say simple, but sometimes difficult to actually do in intubated patients. But even in patients who are not intubated, there's evidence coming that proning, i.e. putting them on their tummy, it actually helps recruit alveoli and helps in their respiration. So something very important. And on a lighter note, something I enjoyed him mentioning is that you lose enough calories just getting your children ready to school. Similar amount of calories as you do with exercise. So that's a good point. On that note, Dr. Kashif, I'll proceed with my talk. Thank you for yours. Although the initial talk was mainly, okay, first of all, let me share my screen. Hold on a second. Can you see my screen now?
Not yet.
Not yet. Okay, just a second. Anything now?
No.
Okay, just a second. I think it's... Nothing coming up yet?
No.
Okay, let me just try again.
If you had not opened up your PowerPoint presentation before starting your Zoom meeting, then you will have to shift to your dashboard in order to share screen. Probably that will help.
Shift to the dashboard. Okay, hold on. My PowerPoint is actually open even before. Otherwise,
but then if you then it should appear on your share screen option, and you should be able to open it through the PowerPoint if it is appearing on your share screen option.
Yeah, it should appear. Let me just try once again. If not, Samreen, you also have a copy. There you go. I think it should.
Are you able to?
Probably Samreen can run it. That's not a bad idea.
Yeah.
If you have a copy.
Try running it, but otherwise, there you go. Maybe it's working now. Can someone see my screen?
Yes, we can.
Yeah. Okay. Brilliant. So, thank you very much once again. My name is Dr. Saqib Bani. I'm a consultant intervention cardiologist at Yaran Valley Hospital in Dartford. Those who are not aware of where it is, it's right at the outskirts of London, towards southeast of London. So very close to London. And I'm also working at Basildon Hospital in the Essex Cardiothoracic Centre, which is also very close to London. Just a brief introduction about myself. I actually graduated from Pakistan, Dow Medical College, which is now called Dow University of Health Sciences. And soon after my house job, I came to UK and did all my training, membership of Royal College and cardiology training in UK, and now working as a consultant for the last 2 years. So the outline or overview of what we will be going through. I will not be going into too much detail about COVID itself, because Dr. Kashif has done a fantastic job of that, and I don't think we need to repeat those things. So I'm trying to focus on the cardiovascular aspect of COVID-19. So we'll discuss the risk factors associated to cardiac patients, managing them on a day-to-day basis. What are the common cardiac complications or manifestations that we come across in our practice? So I'll try and share some of what I've seen in my experience. And then I'll probably put some emphasis on how to deliver cardiology services during this pandemic. And I think that's important to talk about, because whereas a lot of academic stuff may still be available online and people can read it, and also that we are learning as we're going along. So what I might say today might be superseded by new evidence coming up 2 weeks later, but some of the practical tips I can share might be more useful.
Sorry, Dr. Saqib. Can I just mention that there is an extra wide screen coming? This PowerPoint presentation may look different, which is hiding your main presentation stuff.
Gone now?
Yes, thank you.
Okay, sorry about that. See, we're all learning to this technology now, getting used to this. We'll get there. Okay, can you confirm if this is clear now?
It is clear now. It is.
Thank you. So this is what we'll be covering in this session. My screen seems to be stuck. There's some technical issue here.
Okay.
Sorry about that. People who are watching, just give us a moment.
Just give me.
Okay, it's working.
Okay.
It's working again. Right. So, just a brief summary of the global impact. We know COVID-19 is an infectious disease, first identified in Wuhan, China, in December 2019, and World Health Organization officially named it as Coronavirus Disease 2019. That's why we call it COVID-19, not because of what we've heard in social media recently. This was done in February 2020, and it was declared as pandemic by World Health Organization on 11th of March 2020. And if we see what the impact has been as of last night, there have been 9.8 million cases worldwide, and a lot of people still think that this is an underestimate, because not everybody is being tested. So there must be more cases around. But there have been 494,000 deaths, which is about 5% mortality. If I share the UK experience, which unfortunately was not good, we have so far almost 310,000 cases, of which 43,400 have died, which gives us a very high mortality of 14%. But once again, that actually is higher than what it actually is because we've not tested the entire population. But if you look at Pakistan, where I don't think the peak has yet reached, there are 195,000 cases, almost 200,000. But some sort of blessing in disguise, the mortality is almost 2% only, so just under 4,000 deaths. Let's hope the mortality rate remains low, but nevertheless, the disease itself is infectious and spreading quickly. Symptoms, I'm not going to go into details. Dr. Kashif has covered this topic, but just to summarize, that these are the common symptoms, as you can see on the slide. Fevers or chills, cough, shortness of breath, fatigue, muscle ache, body aches, very common, headaches are common, and as mentioned earlier, loss of smell or taste, and nasal congestion. And keep in mind, it's the congestion, not a runny nose. And then sore throat and dry cough, followed by nausea and vomiting and diarrhea, which often leads to dehydration. What happens to the heart in cardiac patients? We know that in COVID-19, the predominant symptoms are respiratory. Okay, it's a respiratory illness, affects the upper airways and then the lungs, but eventually it starts to affect other parts of the body. And people who already have cardiovascular disease are at a higher risk of doing worse if they are faced with this infection. So, are cardiac patients vulnerable? In a nutshell, the answer is yes, because cardiovascular comorbidities are common in patients with COVID-19 infection. We also know that cardiovascular disease is associated with increased mortality in patients who have COVID-19 infection. And cardiovascular risk factors and the disease correlate with increasing age. So not necessary that a heart patient has a higher risk just because he's a heart patient, but probably there's a overlapping phenomena there. A lot of people who are aged also have heart disease, similar to diabetes. So these things, I think, go hand in hand. The more aged you are, the more frail you are, the more comorbidities you may have, and then the worse outcomes from COVID infection. What has been the prevalence so far of cardiovascular disease in COVID? Now, this is variable based on what study you look at. The very initial study from Wuhan showed that 50% COVID patients had comorbidities, and 72% who did not do well had more than one comorbidity. But then there was another study from China which looked at 72,000 patients, but the prevalence was very low of various diseases. For example, hypertension was only seen in 13%, diabetes is only 5.5%, cardiovascular disease in general in 4%. But later on, they found out that this study was underreporting comorbidities because almost half the patients did not mention, or there was lack of data about their comorbidities. But later on, as studies were conducted, I think the quality of studies got better. For example, a study from USA on just under 6,000 patients showed a higher prevalence of comorbidities. And you can see in this slide here, the hypertension was seen in 56% of people who were diagnosed with COVID-19 in the study in USA, obesity in 42%, diabetes in 34%, coronary artery disease 11%, and heart failure 7%. So as mentioned by Dr. Kashif, diabetes and heart disease, general prevalence is about 30 to 50% in patients who are diagnosed with COVID-19. In the UK, there was a study of about 17,000 patients which showed that cardiovascular disease prevalence was just under 40%. So quite a lot of burden in this subgroup of patients. What about hypertension and ACE inhibitors? The reason I've picked up this slide is because there was a lot of discussion, and I think briefly Dr. Kashif mentioned about this. When this whole phenomena started a few months ago, there was a hypothesis that the angiotensin receptor blockers, like ramiprils, lisinoprils, perindoprils, all the tablets ending with prils are ACE inhibitors, or angiotensin 2 receptor blockers like candesartans, losartan, valsartan, they may actually accelerate the viral load because of the way they bind with ACE receptors. But it turned out to be just a hypothesis. A good hypothesis though, but never ever actually proven by scientific evidence. So the current guidelines is that hypertension should be treated as per established guidelines. So people who are taking medications for hypertension should continue taking those medications. If they're already on ACE inhibitors, they should not discontinue it. And then general advice like reducing coffee and tea intake, a bit of exercise, all of this applies. If they have already changed, because the initial theory came along that they should move to calcium channel blockers. So if they've already changed, then it's fine. I mean, the last thing you want is to keep changing tablets amongst in between the pandemic. But the benefit of continuing ACE inhibitors outweighs the risk associated with it. Hence, the European Society of Cardiology and American Heart Association advocate continuing blood pressure medications, including ACE inhibitors, and International Society of Hypertension has endorsed this advice as well. So that summarizes the topic of hypertension. If we then look at the kind of patients who are at risk of developing COVID or doing worse with COVID, in this slide, I've only picked up the cardiac conditions. There's a long list of patients, including patients with cancer, on chemotherapies, diabetes. But here I've just summarized some of the cardiac conditions which increase the risk. For example, patients who had cardiac transplant with their own immunosuppressants, patients who are known to have heart failures or cardiomyopathies, ischemic heart disease, or some congenital heart diseases. And don't forget pregnant people. Pregnant women themselves are at high risk, but if they have underlying heart issues, the risk is much, much higher. So in these patients, there's a concept of shielding, which was recommended by the government in UK. And I think it's important to emphasize here that in Pakistan, although there is a recommendation for self-isolation, this concept of shielding has not yet been widely practiced. And maybe this is something that health physicians should take on board. Shielding basically means asking people to stay indoors for 3 months with only contact with their own households and no outdoor contact with anyone unless it's extremely necessary. So that is something which I think can be taken on board and will be useful because Pakistan is approaching peak now. So what are the cardiac complications and manifestations of COVID-19? I will summarize a few. Firstly, it's worth noting that COVID-19 itself is a thrombogenic phenomenon, and we know this because there is increased evidence of pulmonary embolism and sometimes acute coronary syndrome from thrombus in these patients. And it is also an inflammatory process, and I think these things go hand in hand. We know, and you will see from these patients, that when you admit them and you do blood tests, the troponin levels, which is a cardiac biomarker, is often elevated. And it has been shown that if it is elevated, it is a marker of poor prognosis. So patients do worse. And if you see on this diagram on the right, the red line are those patients who died from COVID-19, and the blue line at the bottom are those who survived COVID-19. And you can see a clear difference that people with normal troponins or very low levels of troponin actually did well, and those who had very high levels of troponin did not do well. So it is a poor prognostic marker. And similarly, BNP, which is a marker of heart failure, is an acute inflammatory response. It also is elevated. However, long-term prognostic significance just in COVID subgroup is not yet clear. We know that higher the BNP, the worse the prognosis in heart failure, but just related to COVID, it's not yet clear. What did COVID do to cardiac emergencies or general emergencies? Interestingly, during the COVID pandemic, especially in UK where we were hit quite badly, there was a reduced number of admissions to hospital via accident emergency admissions, and this was across the board, all across UK. And some figures have shown that the A&E visits dropped down by about 30 to 40% during the peak, and I'm talking about April and coming towards the mid of May. That obviously also resulted in reduced admissions due to acute coronary syndrome, because 30 to 40% of what presents to A&E is often cardiorespiratory in nature. So this is interesting because a lot of people are still confused as to why this happened, and I think only time will tell. There was a concern at some stage that where have these patients gone, because the natural progression of disease will not stop because of pandemic. So either they are worried and they're not presenting themselves to hospitals and they are trying to avoid seeking medical advice, which is often worrying because there's a risk that they may present later with serious consequences, and hence their mortality or morbidity will be higher. Or also because a lot of them are just at home and not exercising, not going outdoors, their symptoms are actually hidden and they may unmask as soon as they start to exert themselves. So, however, interestingly, this concept was this observation was noted that the number of admissions went down, the A&E visits went down, and during the peak, the number of heart attacks being admitted to hospital also went down. And this was also shown in a survey conducted by European Society of Cardiology, which was a questionnaire sent to thousands of medical professionals and cardiologists, and it was a universal phenomenon. Just talking briefly about acute coronary syndrome. I'm not going to go deep into pathophysiology of acute coronary syndrome. I'm expecting a lot of the audience is aware of that. But just to sum it up, we can have angina, then becoming unstable angina, and then people can present with heart attacks, non-elevation or the emergency settings.
So, Dr. Saqib, can you please unmute yourself? Dr. Saqib, can you please unmute yourself? No, still it's muted.
There you go. Can you hear me now?
Yeah, we can hear you now. Sorry,
I think I'm having a little bit of technical issue with my laptop. It's my laptop's fault, not your fault.
All right.
Just bear with me. Okay, so can you see my screen again?
Yes, we can.
So chest pain and breathlessness is a common symptom of COVID-19, and therefore sometimes diagnosing acute coronary syndrome during COVID-19 pandemic can be challenging. Non-COVID acute coronary syndrome patients, when they're admitted to hospitals, it's very important to try and keep them away from COVID areas. And I'm just mentioning this because during the pandemic, and I'll come on to that later, we need to try and make some clean areas of the hospital and distinguish them from the unclean areas where COVID patients are. So normally a COVID patient will go to cardiac ward, but every hospital will have a different setup. I can share my experience because a lot of COVID patients often require non-invasive ventilation like CPAP or BiPAP. And because cardiac nurses are well equipped with this skill, our ward was converted to COVID ward. So all our cardiac patients moved out of our ward, which meant that we had to take extra care of them, well, because they were not under our care directly. So non-COVID acute coronary syndrome patients should be admitted to non-COVID wards and managed appropriately.
Dr. Saqib, sorry, can you just make it full screen? It's again coming as if you do a slideshow.
It's all right now?
That's better, thank you.
Okay, thank you. Some patients with acute coronary syndrome may present as cardiogenic shock as a result of a large myocardial infarction, and these patients may require intensive care support. And they are the ones in trouble. During this pandemic, it's very important to distinguish between what we call type 1 myocardial infarction or type 1 ACS and type 2 MI or type 2 ACS, because they will be managed differently. And just to explain to non-cardiac audience, type 1 MI is the conventional heart attack where there's a blockage in a blood vessel or a plaque rupture disrupting blood flow to the heart muscle. Type 2 is not directly because of a plaque rupture or coronary artery disease, but it's more because of a demand and supply issue. And any strain on the heart muscle from infection, inflammation, trauma can result in myocardial injury, and that's a type 2 myocardial infarction, which is often seen in these pandemics in viral infections. So that's something to keep in mind. The next point to raise is that in general practice, I'm not saying general practice as in GP. In usual practice, troponin rise is taken quite seriously because it's a marker of myocardial necrosis. But in these current circumstances, we have to be pragmatic and practical. So the guidance is that small troponin rises, which are less than 2 times the normal range, in the absence of typical anginal symptoms, should not be treated as acute coronary syndrome. They should not have any further cardiac investigations, particularly invasive procedures. So I think the threshold of when to accept patients for invasive procedures need to change during pandemic, and that's the take-home message here. The other thing to keep in mind is troponin. I'm not entirely sure how commonly it's done in Pakistan, because people can go and get it done themselves if they want to. But in the UK, accident emergency departments send off troponin results quite commonly. But here during the pandemic, it should only be checked if we are suspecting type 1 acute coronary syndrome or there's a new evidence of heart failure. Otherwise, it's not going to change your management, and it is only a prognostic marker in COVID patients. So we have to, take cardiac advice there and use it with caution. And always consider COVID myocarditis in people who present with what appears to be acute coronary syndrome. Okay, there's an overlap in symptoms, and there's something I'll touch upon briefly in coming slides. But in general, just to remember, consider angiography for moderate to high risk cases only, and mild to moderate risk cases, even if they are acute coronary syndrome, can be managed medically given the risk of exposure to other people around. And this slide is basically from European Society of Cardiology, and it just summarizes that patients with non-ST elevation MI during the pandemic should be put into high risk, intermediate risk, and low risk categories. And then if you just follow the flow chart, it just explains that based on ECG changes and ongoing symptoms, you can then decide which patients you need to treat aggressively with invasive procedures, which ones should have non-invasive tests, which is intermediate group, and which ones should just be left alone. And I'm not going to go into details of ESC recommendation, but there's actually a whole document on ESC website, and I'll show you the slide, show you the website in the next slide. It's worthwhile having a look. Coming on to STEMI, ST elevation MI in COVID patients. Now, in normal UK practice, if there is a patient with ST elevation MI, they are rushed to cardiac cath lab immediately and often directly by the ambulance and bypassed from the A&E department, because there's a national target, the universal target of achieving flow or restoring flow in the coronary artery within 120 minutes, that is within 2 hours of onset of symptoms. So there was initial discussion or initial recommendations or experience from China, especially from Wuhan, that they thought that sticking to this protocol might be difficult. But in the European Society, what they've recommended, or even British Society, that STEMI management should continue as usual, because the risk to the heart is too high to be left on conservative management. So we are continuing our STEMI services as usual. However, full personal protective equipment should be provided to all the staff managing these patients in cath lab. I'm emphasizing on the fact full PPE, because there's also standard PPE. A standard PPE might just be a standard mask, gloves, and apron. But full PPE means proper masks, FP3 masks, full gown, covered all around, goggles, and even face visors, because this is a very high risk area, just like you're treating someone in ITU. Why? Because often you're doing this procedure in people who've not had a blood test, they've not had a swab, they've not had a chest x-ray, because if these things are already done, that means the procedure is too late. And if the procedure is being done on time, then you don't have time to wait for the results. So you're often dealing with patients who may have COVID without knowing, and hence you're putting yourself and your staff at risk. So that's why full protection is mandatory. Now here it's worth remembering that coronary angiography itself is not an aerosol generating procedure. And what I mean by aerosol generating procedures is a list of procedures where there is a high risk of spreading the virus because of the germs coming out of the airways. For example, nebulized, as Dr. Kashif mentioned, is an aerosol generating procedure. Similarly, intubated patients or on non-invasive ventilation, CPAP, BiPAP, these are all aerosol generating procedure. Angiography itself is not, but cardiopulmonary resuscitation is, and this is where the dilemma is. So you can do an angiogram. If the patient has a cardiac arrest on the table, performing CPR becomes an aerosol generating procedure. So hence you have to prepare as if you may be exposed to aerosols in future. So COVID testing results, COVID myocarditis can also mimic acute coronary syndrome like STEMI, and this has been seen in our practice here. We have often dealt with a patient who's rushed into emergency cath lab, and it turns out to have normal coronaries, and then 2 days later his swab results comes back positive. And this has been seen a few times. Very quickly at the end of this slide, thrombolysis, which in some areas in Pakistan is still prevalent, but in Western world is out of fashion. But during pandemic, because of practical issues, time constraints, staffing issues, I think there were discussions about it being reintroduced. And although we didn't formally reintroduce it, but I think there were some places in remote areas where it was practiced more commonly than would have been practiced otherwise. So last thing to remember is that STEMI can also develop in a COVID patient while he's in hospital. Don't forget about that. And this is again a summary of how STEMI patients will be managed according to your guidelines. You need to assess their COVID score, and if they have confirmed COVID, then we need to treatment. But if they have no COVID or we don't know, then we go through routine pathway, and you may consider fibrinolysis, as you can see at the bottom left of this slide. This is just a case example of a case that I managed in my hospital. This was a patient who was already in intensive care due to COVID. He was very unwell, got better, was stepped down to high dependency unit on face mask, oxygen, and then developed chest pain and inferior ST elevation MI whilst in hospital. What you can see is an ECG, which shows inferior changes in leads 2, 3, and AVF. So he was rushed to cath lab, and we found that his right coronary artery, which is what you can see at the bottom left, was completely blocked because of heavy thrombotic burden. We successfully managed to open it up, and what you can see in this blue cap on the right is a lot of clot that we sucked out of his coronary artery. And this is more, I mean, we've noticed that during COVID, if there were patients with STEMI, the thrombotic burden was much higher because this is a prothrombotic condition and an inflammatory condition. So this is just an example of what we dealt with, I think, 3 or 4 weeks ago. Moving on from acute coronary syndrome to heart failure, we know that patients with heart failure are at a risk of worse outcomes with COVID. They may present with acute decompensation of already known chronic congestive cardiac failure, but this can also be a late complication of myocardial infarction, and we've seen a few cases because patients did not present early. They were worried about being exposed to COVID in hospital. They stayed at home with chest pain, and they presented 3-4 days later, and by then they had already developed heart failure. But general guidance is that we should treat them the way we treat other patients, and if they're already known to have heart failure, they should not stop any of their medications, particularly ACE inhibitors, which are very beneficial for them. I'll briefly touch upon COVID-induced myocarditis because it's being discussed a lot. This is an inflammatory process. I mean, myocarditis can be because of any viral illness, and COVID is no different. So it can mimic acute coronary syndrome with chest pain and also ECG changes, and it can also present as heart failure. Chest pain, shortness of breath, ECG changes, elevated troponin levels, impaired heart function, cardiac arrhythmias as well, and cardiogenic shock. Myocarditis can present in a lot of ways. How to manage them? There is still emerging data. So I've actually written here lack of data, but I'll probably say there's emerging data. So the data keeps changing from time to time. We're not yet sure what the best management might be, but recent anecdotal evidence has shown that colchicine, which is a very strong anti-inflammatory agent, might be useful in acute myocarditis. And that is now being used. Certainly in my hospital, I've used it in some cases, and my colleagues have also started using colchicine. It was used before as well, but I think there's more evidence now to use it. Some of these patients might be unwell, and they may already be requiring steroids like dexamethasone because they are requiring oxygen. So this is another example of an ECG with acute myocarditis. I'm not sure how clearly it's being projected in your screens, but what it shows is ST changes, ST elevations in anterolateral leads and also inferior leads. So often these patients are just treated as pericarditis, but sometimes they're very unwell and thought to be acute STEMI and only diagnosed after having an angiogram. So there should be a high index of suspicion in COVID patients. That's the bottom line. It's an inflammatory process, as briefly mentioned. And just remember, often troponin levels are massively elevated in myocarditis. So if you compare myocarditis with a myocardial infarction, the extent of troponin elevation is much higher in myocarditis because of the extent of the myocardium being involved. Whereas in true myocardial infarction, it's only a portion of the heart muscle which is damaged. So this is just anecdotal. There's no comparative studies, but in my observation, the troponin levels are not as high in MI as they might be in myocarditis. So I've already mentioned steroids might be used. Colchicine 500 micrograms twice a day for 3 to 4 months is often recommended. Personal experience, I've used it with some beneficial effects, and you continue standard heart failure medications. This is another example of a COVID case that I managed recently, a 60-year-old chap. He had recovered from COVID 2 weeks before coming into hospital. So he'd already been through the COVID phase. But he was known to have dilated cardiomyopathy. Now, we know that cardiomyopathy patients and heart failure patients are at increased risk of doing worse. So this gentleman in the initial phase was actually, he did very well. He recovered at home. He did not even require hospital admission. But 2 weeks after that, he presented with a collapse, proceeded with palpitations. And we noticed that he had ventricular tachycardia when he presented, and this was confirmed on the heart monitor. And when we repeated his heart scan, his heart function had deteriorated from ejection fraction of 40% down to 25%. So this was not a pulmonary edema picture, but he presented with worsening heart failure as a result of COVID myocarditis. And this actually presented as an arrhythmia rather than chest pain. So the take-home message is that arrhythmia, cardiac arrhythmia, can also be a presentation. And this gentleman had normal coronary angiogram, but because he had collapsed with syncope and had VT, he had internal cardiac defibrillator implanted before he was discharged. So an interesting case. And since then, I've seen another case of VF arrest, ventricular fibrillation arrest, in someone who presented only 2 days ago, and I did his angiogram, and angiogram was fine. And only after that, we saw his X-ray and blood tests, and this chap had COVID. So patient was already at home with COVID, maybe managing himself or trying not to be in hospital. We're not entirely sure because he's still not awake, but he presented with cardiac arrest. And as Dr. Kashif was saying earlier, some patients are dying of heart attacks, and they are undiagnosed COVID cases. Very briefly on stress-induced cardiomyopathy. COVID pandemic is a stressful era. And for those who don't know what this cardiomyopathy is, there's a Japanese name given to it called Takotsubo cardiomyopathy, because it's triggered by a stressful response like family bereavement, someone dying, attending a funeral, having a major operation, trauma, major injury, head injury, sometimes stroke, or phenomena like earthquakes, floods, natural disasters. They then result in a stressful response which causes a transient hibernation of the heart muscle, where the muscle is stunned. And patients present with chest pain, ECG changes, and troponin rise, and they also mimic acute coronary syndrome. But when you do an angiogram, it looks fine. But what you see on the heart scan, echocardiogram, is that the tip of the heart does not function well, whereas the base of the heart functions well, and that's why it's also called, to the cardiac audience, if there are cardiologists there, it's also called apical ballooning syndrome, because the apex does not contract, the bases do, so it looks like a balloon. But it's a transient phenomenon, and it recovers in 3 to 4 months, and that's the good thing about it. So incidence of Takotsubo cardiomyopathy or stress-induced cardiomyopathy rises after earthquakes, natural disasters. Hence, I think we should prepare ourselves for a similar trend which may be expected during or soon after COVID pandemic is over. And that reminds me of a case that I managed yesterday. Only yesterday, we had a lady with Takotsubo cardiomyopathy who had been very stressful for 2 weeks because she can't go to work, family is unwell, and family member has died from COVID, and she presented with Takotsubo. Hopefully she'll be recovering in a few months. So moving on to the last segment of my talk, which I think probably, I think is more important than the other stuff I've mentioned, because the other stuff is more theoretical, more, subjective. There's evidence for it, or lack of evidence for it, and people can read online as well. But what I'm going to share in the next few slides are probably some practical aspects of how to deliver cardiology service during the pandemic, because there still remains a challenge. And I think it's a two-way learning process, because whereas I'll share my experiences, I will also like to hear from people who are doing cardiology in other places, particularly in Pakistan, if they can later on share their experience and see if I have something to learn as well, because I think it's still a two-way learning process for everyone. So some general challenges. There are challenges with personal health and safety. Your personal health is the utmost priority, and that of your family. Staff safety is an issue. Staff sickness levels, and then the need for redeployment into high-risk areas or high-demand areas is to be considered. There's a challenge about availability of appropriate PPE, and the emphasis is not just on PPE, but also on appropriate PPE. Then patient safety. Patients need to be kept safe. If they don't have COVID, they are at risk of developing COVID if they're in hospital. There's uncertainty about what's going to happen, and there's lack of preparedness in general. And UK was very unprepared. We have to put our hands up and accept that. And then sometimes you have to think about being in a war zone. You know, what would you do if you're in the middle of a war and you're dealing with a cardiac patient? So sometimes you have to think like that. And then the importance of communication. I think that is something which is ignored, something which is underestimated. The importance of effective communication within the teams, within the hierarchy, right from the top to the bottom, from directorate level to junior doctors, trainees, students, nurses. I think it's extremely important to have efficient communication, because that can take away a lot of confusions. And then finally, there's an anxiety and stress amongst patients, and patient expectations are very different during pandemic compared to what the expectations are in normal days. So these are the challenges that we face while trying to deliver the service. We have to strike a balance between emergency service and elective work. Now, before I go take it forward, I think it's important to realize here that while I'm speaking on behalf of experience from UK, I'm sharing my own experience. UK in some ways, although we were quite badly hit with COVID, but we were blessed because we had NHS. And NHS, which is a state-sponsored health system, is a huge blessing. Not just a blessing for people, it actually helps standardize the care, irrespective of where you're working, whether you're working in a big city or a small town, in a big university hospital or a small district hospital. It actually helps standardize the level of care that you provide to patients. But I appreciate that in places like Pakistan or other places, the healthcare system, or particularly cardiac services, may vary from places to places. So one hospital may have completely different setup from the other. Private sector will have a completely different services from government sectors. So I think a universal adaptation or universal recommendation is not going to be practical in Pakistan. So my recommendation will be that every hospital should look at their own facilities, look at their own capabilities, maybe give autonomy to their own cardiac specialists, and let them come up with their local guidelines. And I think that might work more effectively. So moving on from there, in our experience, our cardiac ward, as I've mentioned before, was converted to COVID ward, and this may happen in other places. So you have to be mindful of that. You have to think about how to deliver your cath lab activity, which includes coronary angiograms, intervention, pacemakers and devices, and other cardiac diagnostic activities, which is like basic things like ECG, ultrasound scan like echocardiogram, exercise treadmill tests, cardiac monitors, blood pressure monitors. I forgot to mention CT coronary angiograms and cardiac MRIs and nuclear perfusion scans. All these things contribute towards diagnostic aspects. So all these things need to be kept in mind. And then how to run outpatient cardiac services like chest pain clinics, consultant clinics, heart failure clinics, electrical DC cardioversions. So there's a wide spectrum of cardiac services which were all affected by COVID. So what did we do? We tried to have meetings amongst ourselves. Although in some centers all elective work was cancelled for 4 to 6 weeks during the peak. In my hospital, I think it was smartly dealt with, and our directors allowed us to decide for ourselves. So we looked at our own elective lists, each operator, and we identified patients who we felt, although were on elective waiting list, were actually semi-urgent because of the nature of their heart condition. And we performed their procedures. And we noticed that whilst the outpatient work was put on hold or reduced by at least 80 to 90%, this actually created a lot of slots and spaces for inpatient work to be done promptly. So whereas previously our inpatient acute coronary syndrome patients would wait 2 or 3 or even longer, 3 days, to have an angiogram, we actually tried to turn them around within 24 hours this time. So we used the slots, but we shifted them from elective to emergency or urgent inpatient work so that patients can go home as soon as possible, so that their patients are exposed as little to COVID as they can. So that was one shift in our practice. And looking at diagnostic work, we actually put most of it on hold. Echoes, ECGs, heart monitors, they were only done for emergencies or really urgent cases, otherwise most of the work was put on hold. Something to remember, during the pandemic, even the resuscitation guidelines were changed. You know, cardiopulmonary resuscitation, which we do in cardiac arrest. I'm not going to go into full details, but I've just shared this picture of the algorithm of advanced life support, which is available on resuscitation website, and everyone should have a look at it. And maybe cardiac departments in your hospitals in Pakistan, they should print them off and display them. Why is it important? As I mentioned earlier, CPR or cardiopulmonary resuscitation is an aerosol generating procedure. It increases the risk of virus being inhaled by the team members who are performing CPR. Therefore, personal safety being first, if a patient with cardiac arrest is identified who's known to have COVID, there's emphasis, and as you can see on this slide, I'm not sure if I can move my cursor, but the emphasis on PPE. The people performing this procedure should be fully gowned and wearing full PPE. And if they are already dealing with a patient who then develops cardiac arrest, the advice was for the team dealing with the patient to step away, which is a very difficult thing to do. Emotionally and ethically, people feel that they're obliged to continue CPR. But the guidelines were for people to step away and allow a dedicated COVID cardiac arrest team to take over, which obviously means that there will be a delay in dealing with the patient. But this is primarily to protect the staff from being affected by COVID-19. So this is something to keep in mind, and this obviously has an impact on how we deliver our emergency services. How to deal with STEMIs? I've already mentioned that all STEMI patients were to be treated as potential COVID patients until proven otherwise, because their diagnostic tests are not available at the time of doing the procedure. But at times we can use thrombolysis rather than routine emergency cath lab work. Coming back to inpatient cardiac services, there was a reduction in the number of acute admissions I've already mentioned, which allowed rapid and timely inpatient management. Patients had angiogram within 24 hours, so we tried to send them home as soon as possible. COVID ward was changed to cardiac ward was changed to COVID ward, so it meant that there were challenges with cardiac monitoring because the wards where patients are kept did not have monitors, and this can also happen in Pakistan. So CCUs may be used for COVID. So as much as we try and keep them separate, it creates a new challenge of monitoring them appropriately. And that brings the concept of being a step ahead, trying to identify patients at the start of the day. Where are those cardiac patients? If they're not on our ward, where can they be? Can we review them first? Can we make decisions early? Do they need to stay in hospital? All these things need to be taken into account. And then use of telephone advice where appropriate, because in UK there's often reliance on inpatient cardiac opinions, and our registrars and trainees go around seeing patients as well as us consultants go around. But during the pandemic, we have to change our practices. And rather than face-to-face assessment, some patients can be given advice over the telephone. What I mean is, some physicians who are requesting cardiac opinion can be contacted on telephone, and the advice can just be given on telephone if it's simple and straightforward. And that reduces the risk of infection. The whole idea is to minimize patient and doctor movement between wards to reduce cross-infection. And that is how the cardiac service needs to adapt, or maybe all other services also need to adapt during the pandemic. What do we do to routine outpatient services? Most outpatient work was either cancelled or deferred. Now that we are relaxing the rules in UK, the service is resuming at about 50% of our capacity. It was very important, we realized, to communicate with patients, because patients are already anxious. They're sitting in the community waiting for tests. Maybe here, Pakistan practice is different. Patients can pay and be seen the next day, but in UK they wait until they're seen by a specialist. So the anxiety levels build up. And when they're told that they have to wait another few months, they get quite upset. So communication with the patient is key. And I think this good communication applies to everywhere, including Pakistan. So if you are going to defer your patients, make sure you reassure them, explain the reasons why. But at the same time, very important to tell them not to avoid coming into hospital if they're unwell. So if they are unwell, they should still seek expert opinion, come into emergency department, because the risk of acquiring COVID is lower than risk of having catastrophic consequences if they're not treated promptly. So when the outpatient service is reduced, what you might notice is that people or nursing staff who deal with outpatient work have relatively less amount of work to do. So that allows you to redeploy them in the areas where there's high demand, which is wards. Because in wards, you will notice that at peak, 25% staff may be off sick, and you have to prepare for that now. So Pakistan peak has not reached yet, so maybe that gives you time to prepare that. What did we do with cardiology clinics? We didn't cancel them in my hospital. We continued with all the clinics, but they were conducted over the telephone or video conference call, so they were virtual clinics. And that might be the new normal going forward, something we all need to learn. Very quickly on PPE for the staff, as mentioned, availability of appropriate PPE is extremely important, but regular communication with staff related to changing guidelines. Guidelines keep changing, and that can be confusing and frustrating. Also, don't forget, your staff members can also be patients. You know, we focus so much on the patients, we forget about the staff sometimes, and we've noticed so many healthcare staff have died. Patients, doctors working in hospitals may have asthma, they may have diabetes, hypertension, obesity. These people are at risk. In the UK and Western world, there's a concept of BAME community, black and ethnic minority groups, including Asians, South Asians. But in Pakistan, everybody is BAME. So you're all at risk. Luckily, the mortality rate is low, but I think it's important to identify those at higher risk amongst yourselves. So within your departments, if you can shuffle your working schedule in such a way that not everyone is there at the same time. There's no need for 5 doctors to be sitting in the office at the same time. You can scatter your working hours around. And also the ones who have multiple comorbidities can be moved out of acute clinical care area into more administrative roles, you know, temporarily. So this is something you'll all have to do and think outside the box. And within your teams, you know, just help each other. And probably that's the best advice I can give you. What about resuming the services? Now that we're relaxing rules, hopefully, inshallah, in Pakistan, once things settle down, activities will resume. I'm already aware that routine work is going ahead in Pakistan, but I think it will be controlled, in my opinion. We are now to adapt to the new normal. And what is this new normal? In our hospital, we are resuming elective work at 50% capacity, and the main reason for that is we don't want to jump the gun too soon. We don't want to open up our doors to the second wave too quickly. On a lighter note, if you don't let the first wave finish, the second wave will never arrive. But that's just a joke. But the idea is also to keep more gaps between patients so that there's more time gaps and there are less people waiting in our waiting area. And that also protects the staff as well as the patients so that we can safely apply social distancing measures of being 2 meters apart, whatever it might mean. And more use of virtual clinics wherever possible. And then the new concept of one-stop sessions. And this is something that people need to adapt. And I think it'll be interesting if people in Pakistan can think of how they can deliver this. What I mean by that is, when patient needs more than one test, then rather than them coming on 2 or 3 visits, if they all can be collaborated and performed on the same day, it would mean that they would stay in hospital for longer on that particular day, but it will reduce the number of visits. And I think that will reduce the risk of exposure to them as well as to staff. And it will also be time efficient. But this requires some administration. This is just an example of the new normal. These are pictures of my hospital, where top left, you can see the reception area, which is now covered with the glass shield, just like if you walk into a departmental store. You can see the yellow tape at the bottom, reminding people to stay away from the desk so that they're not touching the wooden material because viruses can stay everywhere. If you look at the chairs, you know, they've been marked in such a way that people can't sit next to each other. I appreciate there are challenges in Pakistan sometimes because of higher number of people, but and also keeping in mind some people might just remove this note and use the seat. So you need to think of smarter ways in Pakistan of how to stop people sitting next to each other, and you might need to just actually cover the seats in the waiting area with plastic sheets so that people can't physically use them. And the picture in the middle is our cath lab waiting and recovery area. And whereas there are 6 bays on a normal day, as you may appreciate, we are using only 3. So half the number of patients and increased gap amongst the patients. So this is the new normal going forward as we come out of COVID pandemic. And just to conclude, keeping an eye on the time clock, that COVID-19 has been and remains a major challenge for healthcare globally. And UK experienced a very high number of cases, and there were deaths among healthcare workers. In Pakistan, there are challenges due to socioeconomic status, and the challenges are different in every country. Therefore, people need to prepare differently, but we can learn from each other. We don't think the peak has yet reached. I hope it's not a big one. But to summarize, cardiac involvement COVID is a poor prognostic marker. So if the heart is in trouble, the patient is in trouble. You sometimes need to think outside the box. Routine guidelines may not apply to everyone. And acute myocarditis is more common than in the past and can mimic acute MI. Staff safety is paramount without compromising patient safety. And we need to strike a balance between delivering emergency and routine work. Guidelines and recommendations are evolving as time goes by, and therefore, in 2 weeks from now, some of what I've said may be obsolete. On that note, I'd like to thank you all, and there's limited time left, but I'm happy to take a few questions, and hopefully we can keep it cardiac oriented because general COVID-related questions have been addressed by Dr. Kashyap already. Thank you.
Thank you so much, Dr. Saqib. It was a very useful session, and I think the main thing which you have mentioned again and again, which is communication. So communication is the key for any specialty to deal with COVID. Is not only the communication, but the professional communication, and also through the government to make people more aware about it too. So we are ready for the question and answer session. So if anyone would like to ask any question, they can raise hands or can send a message in the chat box. Yes, Dr. Amir Shehzad, do you like to ask?
I'm Dr. Amir. I have a question that what is your experience of safety of Azomax in cardiac patients as far as cardiac side effects are concerned, prolongation of QT interval in COVID-19?
Yeah, so I think Dr. Kashyap also briefly mentioned that. Now, it's a prolongation of QT interval is a recognized complication of use of these drugs. However, in a vast majority of cases, it's not been a major issue. And regarding QT, it's worth remembering that a minor prolongation of QT interval outside the normal range does not result in cardiac arrest or cardiac arrhythmia. And for a QT interval to lead to cardiac arrest, I would not like to see, but I would expect to see QTC, corrected QTC of more than 500 milliseconds. If it goes to that extent, then you're likely to have cardiac arrhythmias. But in UK, in our practice, we actually did not use this drug much. So our experience was very limited. Practically speaking, we did not see much QT prolongation, purely for that reason, because we did not use it widely or widely enough.
Do you recommend that a drug should be stopped in case of COVID myocarditis?
Probably yes. I mean, I think steroids will be better off with colchicine. So I think colchicine is a better anti-inflammatory drug. If your cardiac muscle is already involved, there is already a risk of cardiac arrhythmia. And in that case, any drug which has a potential side effect of cardiac arrhythmia should be avoided, including the ones you mentioned. Yeah, that's a good point.
Thank you very much.
There is a hand raised from Doe University of Health Sciences. Can you please unmute and ask your question?
Yes, I am Dr. Azizullah, infectious disease consultant. Thank you, Dr. Saqib, for your excellent enlightening talk. I have to ask 2-3 questions. Number one, I see in my couple of patients tachycardia. Despite that, they are afebrile, their oxygen saturation is normal, the inflammatory markers are downtamed, but their heart rate is really going to 130, 140, 145. So advise us what can we do for those patients. Another question is, do you see any role of aspirin and clopidogrel in patients who are young, healthy, and having mild COVID disease or at home isolation? But a lot of people are asking about aspirin and clopidogrel. And I have one patient who landed in our hospital with complete heart block. But before procedure, we did COVID PCR that turned out to be positive. Then our EP services said that we will do the temporary permanent pacemaker, but we can't do the PP permanent pacemaker. So can you advise us what is the ideal time of doing PP in these patients? Thank you.
Thank you very much for your questions. I think they're all quite relevant questions. Starting with the first one, you talked about tachycardia. Now, sinus tachycardia is a very common phenomenon noticed in people who have any form of infection. And we must remember COVID infection is systematically much more severe than general infection that people suffer with. So the degree of tachycardia is probably higher. So it probably still is physiological. But what is worth remembering is that aggressive or appropriate fluid rehydration can sometimes help. Often these patients are dehydrated. They are hypotensive, and that's why tachycardia is a reaction. I wouldn't recommend chasing or treating tachycardia with drugs like beta blockers. They should probably just be left alone. Tachycardia will eventually settle down once the infection settles down. So focus on the infection rather than tachycardia. So that's the general advice on tachycardia, but it's worthwhile making sure that a cardiologist has seen the ECG and it's actually just true sinus tachycardia. For heart rates above 150, I'm slightly uncomfortable with that sinus tachycardia because then often there's something else wrong. Either they're developing some sort of atrial tachycardia or narrow complex tachycardia. Then expert cardiac opinion should be sought. Second part of your question was about blood thinners. So young people who are generally have mild symptoms and they're at home, there's no role of aspirin and clopidogrel. In fact, long-term use of aspirin and clopidogrel can have GI symptoms, gastric erosions, and we often get GI symptoms with COVID anyway. So let's not make that worse. But for those people who are admitted to hospital, i.e. moderate to severe symptoms, they are at increased risk of thrombogenic phenomena, deep vein thrombosis, pulmonary embolism. So in those cases also, aspirin on its own is not that beneficial, but what people have recommended is use of a slightly higher dose of lower molecular weight heparin. Normally, whatever dose you would use as precaution in the hospital, the recommendation during COVID is to use a slightly higher dose. This is from hematologists, so that the risk of DVT and blood clot formation is low. If those patients are already on aspirin, we would continue. And if those patients have underlying coronary artery disease, then yes, there's a role of aspirin, but not just for COVID, but that's predominantly for coronary artery disease. And finally, you asked about patients with complete heart block and COVID. Now, that's a tricky situation because the timing of pacemaker will actually depend on the hemodynamic status of the patient. So if the patient is unwell and not coping with due to bradycardia, blood pressure is low, risk of cardiac arrest, then the risk of infection is lower than risk of death, and the pacemaker needs to proceed. In such circumstances, some specialists, what they do is put a temporary pacemaker. I'm not saying temporary wire, but sometimes an externalized pacemaker. So the wires are in the heart, but the pacemaker sits outside the skin and is just attached to your body with a tape. So the pacemaker device is not permanently implanted, and that can create a bridge and give you time where the infection markers can go down. Because keeping in mind, putting it in a foreign body, which is going to stay in for years, in a status where the body is acutely inflamed and infectious, can be really disastrous. If that foreign body gets infected, then it can be a catastrophe. So it's a tricky one. But in general, having COVID is not a contraindication from having pacemakers. In our center, we've done 2 or 3 cases recently, including the one I presented about, who had a defibrillator actually. All these patients had COVID, but they were not acutely infectious or actively infected with very high inflammatory markers. We gave them enough time for the inflammatory markers to come down to some extent, made sure that there was no supported bacterial infection before we implanted the device, and then we proceeded with pacemaker. So it can be done.
Thank you, Saqib. Got the point.
You're welcome.
Thank you. There is another question from Professor Sophia Farooq, and it's her question is, when and what's the role of the rivaroxaban?
So rivaroxaban is an anticoagulant, one of the dual anticoagulants. People have started using these rather than warfarin. The role of rivaroxaban in preventing blood clots is very limited. I think if they're in hospital, they use low molecular weight heparin. But in people who have atrial fibrillation or people who've developed blood clots like DVT or pulmonary embolism, that's where the role is quite evident. So I would continue recommending use of these drugs where they are routinely recommended, but have a lower threshold of thinking about these drugs, because remember, COVID is a thrombogenic phenomena. It increases the incidence of pulmonary embolism. We have seen that in a lot of cases that when they have CT scans, they have pulmonary emboli. So they do end up on these agents. But routinely giving rivaroxaban just as a precaution, I don't think has any value, and it may actually increase the risk of bleeding if you need it.
Thank you. I think there was another similar question regarding the anticoagulant. It was from Zishan Hamid from the Sindh Government Qatar Hospital, Karachi. And he also asked about the use of anticoagulant use in moderate to severe cases of COVID-19.
Samir, I'm sorry, I missed the middle bit of the question. Can you repeat the question?
So he has asked that the role of the anticoagulants in moderate to severe cases of the COVID-19.
Again, the answer will be the same. If they have got evidence of thromboembolic phenomena, thrombogenic phenomena, then yes, it should be initiated and initiated early. But you might see that the ones who are very unwell in intensive cares on ventilators, they might actually be receiving intravenous heparin at times. If they're on wards, then low molecular weight heparin can be used while bridging onto NOACs or DOACs. But just because they're moderate to severe without evidence of any thrombogenic phenomena, there's very little role of prescribing anticoagulants. If they're already on it for a reason, then that should be continued. Yes, one thing worth keeping in mind is conventionally, when we decide which patient should have anticoagulants, we use scoring systems like CHAS-VASc. CHAS-VASc is used very commonly to identify people at high risk or intermediate risk of thromboembolic phenomena. Now, what's not included in CHAS-VASc is COVID. COVID does not feature in these, routine guidelines. So that's something to keep in mind, that applying those guidelines strictly to COVID patients would mean that you might miss out some people who would benefit from anticoagulation. So the threshold for anticoagulation should be reduced slightly, but not everyone should have it if they don't need it. That's my point.
There was another question which was asked. It was from Dr. Masoom from Sargodha Hospital. And why A positive group patients more prone to COVID infections?
If I'm really honest, I do not know. This is a question for hematologists. But I think there's emerging evidence. You might see that in a few weeks, there might be another blood group which may have a slightly, because this is just one study. And it's hard to comment on that. I don't think there's any direct cardiac association with blood group A, although we do know that different blood groups, can have different association with other diseases. So maybe there's a more of an immunological phenomena there as opposed to cardiac. But if I'm honest, I would refrain from answering because this is not my area of expertise.
Thank you. I will just, I think in the chat box there is, just give me a second.
Well, if you're looking for questions, the other thing I can just maybe add on, because there's a very common question asked in messages, text messages, emails, when to give oxygen.
Yeah.
So patients with COVID, now this is not purely a cardiac issue, it's more cardiorespiratory, but it's all linked to each other. Patients with COVID can tolerate slightly low oxygen levels, and as long as the oxygen levels are above 90% or 92%, there is actually no need to give oxygen. So the advice to general public is to get hold of a pulse oximeter if you can, as Dr. Kashif also mentioned, a really useful tool. What I've recently seen is a lot of friends and their relatives back home have COVID, and they keep monitoring the sats, and they keep sharing screenshots of pictures with the pulse oximeter on the finger, and it's very easy to give advice as to when or when not to use oxygen. Too much oxygen can cause barotrauma in lungs which are already fragile due to inflammation. So it's best to avoid oxygen if you can allow people to be on normal room air, as long as the oxygen is around 90% or 92%. So that's something which I would like to add, which I did not include in my slides.
Thank you so much. There is a hand raised from the Doha University of Health Sciences. Yes, please go ahead.
Assalamu alaikum. My name is Dr. Mohammed Mudassir. Thank you, Dr. Saqib, for the discussion. I need to ask two things. When to start anticoagulants and antiplatelets in young patients, number one. And number two, correct me if I'm wrong, during your lecture delivery, I found that maybe I heard that you said BiPAP and CPAP is not an aerosol generating procedure, whereas CPR is. So correct me if I'm wrong.
No, that's fine. I'll correct you. BiPAP, CPAP is an aerosol generating procedure. It is. So if I was misheard, then I'll correct it. But yes, because there's a lot of aerosol generation during those non-invasive ventilation procedures. So It is aerosol generating. It's just like nebulizers, as Dr. Kash was mentioning. And going to your first question, I've already answered to the previous person who asked the same question, that in young people, if they are low risk and they have mild to moderate symptoms, there's no need to add anticoagulants, antiplatelets, just as a precaution. But if they're known to have coronary disease, then one should argue they should already be on aspirin. But if it's been missed out, then COVID has reminded us to give them aspirin. But anticoagulation, I would only give if there is evidence of thrombogenic phenomena. Otherwise, if patients develop DIC, for example, they develop ARDS, if their immunological response, their antiplatelet activity is also deranged, so they can also bleed sometimes. So we have to be slightly careful. Thank you.
Thank you so much.
Thank you so much. I think we'll end our session over here now. Thank you so much to both our participants, Dr. Kashif Rizvi and Dr. Saqib Pani, for joining, and for all the audience who have joined and participated. It's really highly appreciated. For future, we will be having more COVID-based series on. You can join Impact page to have the updates. Those who join through the conference room, they can send with the snapshots. So thank you so much for joining on behalf of the Impact team. Allah Hafiz.
Thank you, Samreen. Thank you, Impact team.
Thank you. Allah Hafiz.